Hi, everybody. Thank you for joining us this evening. This evening's webinar will be given by Dr. Thomas Dowd, one of our foot and ankle surgeons here at Rothman Orthopaedics. Dr. Dowd sees patients at our Glen Mills, Media, and Westchester office locations. If you have any questions during the presentation, please feel free to enter them at the Q&A box at the bottom of your screen. Dr. Dowd will take time at the end to answer as many as possible, and he also will take time in between if you have any questions that are relevant to the topics that he's discussing. So please feel free to enter them as he presents, and we will get your questions answered. You could take it from here, Dr. Dowd.
Thanks so much, Natalie. It's good to be here. And I'd like to talk tonight about some things near and dear to my heart regarding ankles. Obviously, as a foot and ankle orthopedic surgeon, this is my area of focus. We'll talk about sprains, then we'll talk about fractures, and then we'll talk about arthritis, which can arise as a consequence of both of those clinical conditions. And so here we go. So what is a sprain? A lot of us have used ChatGPT, Claude for AI, and we put these questions in. And if we ask a bad question or we don't ask it right, it comes out with garbage. I asked Claude to give me an image of someone rolling their ankle and a diagram of the ligaments that are commonly torn. And this image came up, and it probably would make Picasso proud, but nobody else. And so you really got to be careful with AI and using that as a source because if you don't ask the right questions, you don't get the right answers. And so I'm here to hopefully answer some of the right questions or at least tell you what the right questions might be and help guide those decisions, as we pursue care for healthy ankles. So what is a sprain? Think about ligaments as the ropes that connect bone to bone. You don't really have control over them, but they hold your ankle in a good spot. When those ropes are torn, things separate. Imagine a boat that's tied to a dock. If that rope is no longer attached, then the boat starts to drift away, and that's not good. In a similar fashion, but on a smaller scale, that's what's going on with a sprain. That's damage to a ligament that connects bone to bone. So your first treatment's pretty intuitive. You get off it. You really don't want to walk when you have sprained your ankle. And so, you've stepped off the curb or you've done a cutting activity and you feel that pop, you notice immediate pain on generally the outer part of your ankle. And so you say, hey, I better stay off this. And then you might want to go seek care. Um, when you do go seek care, you're going to generally get an X-ray. There are certain rules, the Ottawa rules, that folks follow in order to determine whether or not you should be getting X-rays. But oftentimes you're going to get an X-ray and you're going to potentially see an avulsion fracture. And that's a different animal than the fractures we'll talk about later. And continuing on that rope analogy, if you see the rope in the upper right-hand corner, that's tied to a cleat on the dock or on the boat. And if that cleat pulls off instead of the rope breaking, sometimes you can see an avulsion fracture. That still functions awfully similarly. It's just a different manifestation of the same problem where the bones meet up and they're not held together in a stable fashion because those attachments are disrupted. And so, what is the first step in treatment? Well, you want to do RICE and physical therapy. You can do your own activity modifications and your own therapy in terms of kind of getting your range of motion back in a gradual fashion. But certainly there's an option to do it more formally. Commercially available ankle braces, ankle wraps are available to hold it still, at least to give you comfort while you're trying to navigate those early phases after an ankle sprain. And then sometimes you'll have more aggressive braces, more specific braces. But first things first, you want to take those anti-inflammatories, you want to rest it, you want to compress it, you want to elevate it, and see if you can't just kind of get through it without having to seek advanced care. And oftentimes you'll just sprain the ankle. You'll think to yourself, "Gosh, that hurt." You'll kind of walk through gingerly, and then it'll get better, and you'll say, "Ah, I don't need any care." And down the road you might, but oftentimes these major ankle sprains at their first time don't even need to see an orthopedic surgeon like me, and kind of the basics of care will take care of you. To review those ligaments versus tendons, it's a question I often get, and to be clear about what those two different structures are, The ligaments are these ropes that connect the bone to the bone, but they don't connect muscle to bone. That's what the tendons do. The tendons have a job in saying, hey, the motor, which is the muscle, gives a pull, and that makes the tendon move. And as the tendon moves, it pulls on the bone that it's attached to. Probably the most famous of them all is the Achilles tendon. I guess that's why they write myths about it. But that's a muscle connected to a tendon connected to a bone, or an engine connected to a rope connected to a bone. You have control over that. And so some folks will come and they'll have some instability, and we'll try and focus on feeling where the ankle is in space, and learning to control what we call the dynamic stabilizers, meaning those things that we can control and we can move in order to hold the ankle stable. Those tendons depicted on the outer part of the ankle are the peroneal tendons. You can control those and you can pull those. And when your ankle's rolling off the curb, you can quickly sense that change in position and pull your ankle back up into a neutral position. Sometimes, as you're doing that, though, you're asking a lot of it. The muscle hypertrophies and things get crowded around the ankle. Sometimes, as they go around the curve behind the ankle, that can be damaged. And those tendons don't necessarily split like the Achilles can, but they rub like a rope around a pulley or around a pole at the water, and the rope can get frayed, and so that can be a problem. And so tendons, you control them, they can be strained, they can be frayed, they can sometimes rupture in the case of quadriceps, patella, or more focused here on the ankle, the Achilles. But ligaments, those connect bone to bone. We don't really control them, and those are the sprains. So you may have rolled your ankle a while ago and you say, gosh, I rolled this a while ago, but it still hurts. Well, there's a lot more to it than just a simple sprain sometimes, and that's what brings folks to my attention. Inversion versus eversion speaks to the injury pattern, whether you roll and the outer part of your foot hits the ground or the inner part does, that will damage different structures. If it's the eversion pattern, usually it's structures on the inner part of the ankle that'll be damaged. And if it's an inversion pattern, which is the most commonly injured ligament is the anterior talofibular ligament. There's also a question of severity, right? If it's just a simple partial tear, that can be no big deal and kind of one of those things that self-care takes care of and you don't think about it anymore. But sometimes the more severe ones, those grade 3 complete ruptures of the ligaments, can be more severe and lead to greater instability. Additionally, you can have complexity where multiple ligaments are torn. That the ligaments in the ankle, they're like a sheet with functional thickening. They aren't those famous ACL and PCL ligaments that are rope-like structures within the joint. These are on the periphery, they're on the outside, and the lining of the joint thickens in a functional fashion in order to stabilize the joint. And so we really want to see is that sheet torn through multiple of those thickened areas that are those named ligaments that are really, really important. And it doesn't only happen once, it can happen multiple times. As it happens multiple times, there can be damage to nearby structures, or just it can be really irritating to roll your ankle. It's embarrassing, it limits your function, it's really painful. As that happens more and more, that's when you wear a brace, that's when you seek physical therapy, or you say, hey, let's get this sorted out with an orthopedic surgeon who does foot and ankle work, and we get to meet. But those nearby structures that can be damaged, we generally will assess them with advanced imaging and an examination and try and compare the two and see if we can't piece it together and figure out, is this pain coming from damaged cartilage or nearby tendons that have been injured or frayed, like we talked about? Is there a desire of the body to stiffen and stabilize the joint by way of growing osteophytes or creating early arthritis? And is that causing a problem? You can also have those avulsion fractures we talked about, or even small breaks like an ostrigonum that kind of pinches off the back of your ankle and needs to be removed. And then obviously there's the risk of inflammation of the joint. And so we'll be looking for all that. And oftentimes it's with an MRI. But as I alluded to earlier, this is a mentor of mine from the military time, Ray Top, and he would say to me, "Your goal is to win the slot machine." And I was like, "What are we talking about here? We're not gambling with people's lives." And he's like, "Relax. It's just a simple analogy." And what I want to be clear about is that you want three important things to line up. You want to listen really closely to your patients and have them tell you what the problem is. And when you hear what the problem is, that's going to guide your physical exam and direct you. And as you do that physical exam, and you've done several to figure out what normal looks like and what abnormal looks like, you're going to compare that with objective stuff. That objective stuff is generally imaging studies. Sometimes it's labs if you have a different type of illness, but for orthopedics, it's most commonly x-rays. And I love to get those in a weight-bearing fashion, and I'll show you why when we talk about arthritis. But I really like to know about the alignment of the ankle. I like to know if the bony structures, which give the main foundation, if they're intact. And then if I want to look closely at the soft tissue after we've been evaluated or after someone has sent you with an MRI, I'll compare my soft tissue examination with the MRI findings. Now, sometimes we'll do a stress exam where I will put a force on the ankle, and I'll do that with x-rays done at the same time, or a fluoroscopy, which is an instant x-ray. And I'll really compare to see if there's any evidence that I can see that things are unstable. But what we want is those three cherries to line up, that slot machine to have a agreement between the story, the examination, and then also the imaging studies. And when those three line up, we've really won together because I can look you in the eye and say, "Hey, here's the problem," and I think we can head towards some success here. Questions on ankle instability. Has anyone offered any questions, Natalie?
No questions as of yet. If anybody has a question, feel free to enter it now. Any questions on instability? We can wait a minute and see if anybody enters. All
All right.
right. We can
Well,
always jump back at the end.
yeah, feel free. Now, sometimes it's not necessarily a simple sprain. Sometimes you break your ankle and it is devastating. And some people have worse outcomes from sprains, some people breaks, but they're both on a spectrum. This is a really bad one. This is an ankle fracture that is also a dislocation. It's got a really bad prognosis, even after you fix the bones and get things back together. But you can see those blue lines there. Those blue lines should line up. That red circle suggests, hey, this is dislocated and the skin might be damaged. We need to immobilize this. We need to pop this ankle back in place right now and really get it taken care of. One of the residents who was with me today headed off in an expeditious fashion to help reduce an ankle like this because we know it's so important. That act of getting the talus underneath the tibia, the long shin bone on top of the ankle bone is super important. And so we hustle to do that as fast as we can so that the skin doesn't get compromised, so that soft tissue surrounding isn't excessively stretched, and that so the skin can get ready for surgery without undue tension. And so if it's dislocated, that's a bad thing. We want to get it back together and we want to immobilize it with a splint as fast as we can. As you can see, once you put that bone back together, it looks a whole lot better, and patients are really grateful that that's happened just from a mere pain standpoint. And we can get to the project of planning surgery, getting things rested so that indeed the skin is better and more appropriate for surgery. Now, sometimes the fracture pattern is stable. The first example is that of an unstable fracture pattern, and indeed it's dislocated, but sometimes it looks relatively stable. And the mortise, which is just like mortise and tendon joinery, where the underlying bone, the underneath bone, the talus bone sits under the tibia, and that dark line that almost looks like an upside down U, that is perfectly in line as it goes across, and the fracture is not unstable. If I see that, and especially if I see that on multiple weight-bearing x-rays after the injury, we can oftentimes treat it without surgery. Sometimes we have to do those additional stress exams, like I alluded to, in order to see if it is indeed stable, because sometimes you need to check with more than just the weight-bearing x-rays. As you can see in this example, the fracture pattern's unstable. I shouldn't be able to squeeze a yellow box in there between the talus and the tibia. That means that the bone on the outer part is broken and shifted, and the ligament on the inside that acts as a rope to connect the bones that are typically right next to each other, that's been disrupted. And that outcome is a whole lot worse. Bill Hamilton up in New York did a great study on the importance of the bone being aligned properly in order to have the proper area of contact. Just a millimeter shift can influence the contact area by 40%. And so if that contact area goes down, the pressure goes way up because the force is generally the same from the human body. And so it's really important to have this game of millimeters won. And so anytime we see that space that's represented by the yellow box there, we really want to advocate for eliminating that space, and oftentimes it's surgical. Now, there may be injuries you have that it's far more severe and you develop these bubbles, and people are like, what on earth is this? What's going on? That bubble is a fracture blister. And it used to be that we thought they were sterile. There was a recent study that suggested that there can be some bacterial colonization in there. And so sometimes we'll unroof those and keep them clean. Either way, we don't want to do surgery through them. That bubble is a sign that, hey, this is not only a broken bone, but there is a huge soft tissue injury that is associated with this. And so what we'll do is we'll do a staged procedure. We won't necessarily immobilize, although sometimes we will, but oftentimes we'll have to do an external fixation where we put pins in the bones that are separate from the fractured bone, or at least remote from the fractured bone, and then connect them with these bars that you see that blue glove is grabbing. And that will externally stabilize and basically make a bridge that surrounds the broken bone to hold it together while the soft tissue rests. And so know that sometimes the severity isn't manifest necessarily only in the bone, but also in the soft tissue. And we really have to respect that. There'll be some examples why. Now, we always want to know the status of the nerves and arteries. Some people can have diabetes. That's a really big problem for my patients, and we like for folks to regularly check their hemoglobin A1C. If it's less than 6.5, the risk of complications is about the same as your average surgical patient. But if it's more than 6.5, especially in the teens, I'm really worried. And I'm saying to myself, I don't have time to optimize their insulin for a 90-day course. I have to get this bone back in the right spot, but I don't want to add insult to injury and cause further harm by my surgical technique. And sometimes what we'll do is we'll do percutaneous or very small incision surgeries like that, which is represented here, where we place a nail through the heel and into the leg bone and bypass the fracture altogether. And then we connect it with screws above and below so it doesn't rotate. And we say, hey, your nerves aren't good, and you're going to walk on this fracture and you're not going to feel it. You're not going to know it hurts. You're not going to know you're not supposed to put weight on this. You're going to do it anyway, and it's going to fall apart, and it's going to be a bigger problem down the road. And so sometimes we'll just reinforce with these nails. Now, similarly, arteries can be a problem in diabetics, or whether you're a long-term smoker, or if you have vascular disease. Often people who previously had heart disease have vascular disease in their peripheral arteries. And so bad arterial supply oftentimes equals difficulty healing wounds. And so that's another reason to consider what we call minimally invasive surgery, less invasive surgery, smaller incisions, so that we're asking less of the blood supply, which is already limited. We're saying, hey, we're gonna minimize those big wounds on the side of your ankle to get you to heal as best as possible with newer techniques. And so nerves and arteries, the status of those are super important. We'll often check for protective sensation with a Semmes-Weinstein monofilament. It's just this little thing that looks like stout fishing wire. Um, but it's super important. So definitely control your diabetes if you're well, living that life. And if we do have diabetic issues, we really want to be savvy about accommodating that problem. Now, this is why nerves and arteries and the status of the skin is so important. If you operate through blisters, if you make large incisions through people with bad blood supply, sometimes that wound can get larger. Sometimes the skin can die in its entirety in a full thickness flap. And when that happens, it's very complicated in order to address. And sometimes you have to rotate tissue from nearby. Sometimes you need a wound vac. So many different potential issues that arise, and so you have to be really savvy about saying, hey, how do these nerves function? Especially how are the arteries functioning? Do you have a pulse? Can we address this differently so that we avoid this? The old saying, an ounce of prevention is a pound of cure, right? So we look at these plans and we say, okay, we're going to have to do internal fixation, but especially in those patients with poor blood supply, sometimes instead of those yellow incision lines, we're going to make stab incisions as represented by the green arrows. And so the wound burden, although it's multiple stab incisions, it's fewer in its length or lesser in its length than a long yellow wound like you see depicted here. And we're not stretching the tissue in order to get it out of the way. We're just using instant X-ray to guide placement of that nail and those associated screws. And so just because you have diabetes or poor blood supply doesn't mean that's the end of the story. It's just we have to be savvy and judicious in our use of open means. One of many problems that can arise is depicted here in this picture, and that's a malunion, where the bone doesn't heal in the right spot. But oftentimes I'll talk to my patients about the potential problems that can arise with surgery. And it may go over your head if you've got tunnel vision and you're thinking to yourself, gosh, I just broke my ankle and now this guy's throwing all this jargon at me it goes over your head. So it's nice to be able to talk about this in a more controlled setting and kind of describe these risks that are involved in surgery. So this came to me from a different surgeon, but a malunion is where the bone doesn't heal in the right position. And you can see how that ankle is tilted. The talus has an angle to it sitting under the tibia and the fibula. It just doesn't look like some of those nice x-rays we showed previously. That screw is also rubbing on the top outer part of the talus bone, and the inner bone there, the medial malleolus, really is nowhere near where it's supposed to be. And so this has to be rearranged. And so you'd like to avoid this to begin with certain techniques that would help you to not have this problem. But a malunion can arise for a variety of causes, to include Charcot-arthropathy or the problem that arises from diabetics who lack protective sensation. The hardware can irritate. As you can see, that screw is resting right on the top of the talus bone on the outer part. And when that screw, which is supposed to just be in bone, is actually grinding on cartilage that's supposed to be smoother than a cue ball on a billiard table, you know that problems can arise and it can be awfully painful. As we alluded to with the Charcot-arthropathy, this patient had a really minimally invasive technique done by a different surgeon, and the nail is a great idea, but if folks walk on it ahead of time, they won't even feel this falling apart, and they'll look down at their ankle and they'll say to themselves, "Why does it look like that? That looks a little off," but it won't correlate because the pain won't be there, and so if there's no pain, they're not going to say to themselves, I need to get this checked out. And it can go a long, long time. And then bone or even hardware can be popping through the skin. And so for me, if you've got Charcot-arthropathy or the risk of developing Charcot-arthropathy, I'll see that you don't have protective sensation when I press that really thick fishing wire on your foot. And if you lack protective sensation, oftentimes you're not walking on this thing for a good 3 months after surgery. Now, here's a trick question for you. Surrounded in blue there's the outline of old screws that are placed, and I had to take that out in order to treat this new fracture. So people will often say, well, if I get my ankle fixed, or is there a potential for problems? Well, in terms of breaking it again, yes. if the plates and screws are in, oftentimes you just break in a different spot. And so it's not as though it shields you from ever breaking again and makes you a bionic human. It's going to shield that area, but certainly there can be fractures in new and different places, despite the fact that you've had your ankle fixed before. And then we talk back about malunion. This is a more complex version where it's more of what we call a pilon, where you don't have a rotational ankle injury, but you fall from height. But sometimes a surgeon will fix it and it will end up tilting and going out of alignment in terms of malunion. And you have to get it straight. The angular, like whenever it tilts, that'll overload one side or the other and can cause a real problem. And so you have to do really extensive surgeries, oftentimes re-breaking it. But you can have broken hardware when this malunion occurs, as you can see in those pictures on the left. And so you have to be real aggressive about straightening it out and holding it together with some aggressive techniques. You can see an intramedullary rod that I used to straighten this patient's leg out, and then some really robust plates that are bigger than what we saw previously. You got to be aggressive when you're redoing surgery. It's quite important. Any questions on those ankle fractures?
Yes, there is one.
Okay.
And then one about back to sprains.
Oh, wonderful.
With a fracture in the ankle, how does osteoporosis affect the outcome?
Yeah. Um, So osteoporosis is on the spectrum of weakened bone. Osteopenia can be identified where we say to ourselves, okay, the bone is weak, but not super weak. Osteoporosis, it's really quite weak. And so that presents a challenge to me because that is not good bone to fixate with the hardware we put in. There's a mismatch between the strength of the plates and the screws. And so you have to talk to someone who's well versed in those additional techniques that help people with osteoporosis. I had shown that previous image of the nail going up the middle of the ankle through the heel bone. That is a technique that's wonderful for patients with osteoporosis in terms of letting them walk again quickly and being strong enough to share the load. We call those nails load sharing devices, and they're biomechanically advantageous. Now, you can augment with additional screws, additional wires. You can put cement or polymethyl methacrylate. Fun fact, that's just plexiglass in a different form. And you can put bone cement that we might use to replace joints. You can put that cement in to reinforce the bone and make it stronger. The bottom line is your surgeon needs to be aware that you have osteoporosis and come up with a plan that says, I'm going to address that head on, whether that's augmenting the strength with cement, augmenting it with extra plates, augmenting it with extra screws, or using that tibio-talocalcaneal nail, which has advantages for people with bad arteries and nerves, which can all often go hand in hand.
Great, thank you. The question relating to sprains was, does posterior tibial tendon dysfunction relate to ankle sprains? They said they've had both several times.
It's an interesting question and it's an evolving one. Usually, we like to think that inversion injuries, which were the most common sprains, don't go hand in hand with posterior tibial tendon dysfunction. But that's not always the case. There can be some overlap, and those are really tricky cases to discuss. And you really have to dig deep in terms of sussing out, hey, is this more of an instability problem? Or is this a complex instability problem where multiple structures are damaged, both on the outer part of the ankle and the inner part of the ankle, and the posterior tibial tendon isn't the source of the problem, but it's bearing the burden of that instability and it's trying to be a dynamic stabilizer and it's just struggling. And so it's a chicken or the egg discussion. It's a nuanced discussion, and it's one that is informed by the examination, the MRI, and most importantly, your history. And so that's a difficult question to answer. And then we could go even deeper with some of the research that's going on into some of the ligaments we had previously ignored that are now being implicated in the development of progressive collapsing flat foot disorder, which used to be posterior tibial tendon dysfunction. So without getting too deep into the weeds on that, yes, there's an association. It's not a common one, but it is an important one to not miss if there is an involvement of both of those structures or multiple structures.
Great, thank you. Does using screws and plates bring on early arthritis? Is it true?
That is probably more of a correlation than causation issue. There are some studies that analyze the pressure on a joint from nearby screws. I remember in board collection, I got in trouble with Art Manoli, may he rest in peace, but he asked me why I took a screw out of a patient's ankle. And I said, well, he was having pain, and I took it out because I didn't want there to be undue pressure. And there's not a lot of high-level literature on that. And that's probably why the board examination, 15 years ago was a little bit more difficult than it had to be. But no, remember when we used to think that gamblers got cancer? And really, it was the fact that there was more smoking happening in there, and that led to the higher cancer rate. The real issue is that the trauma occurred. So the screws have to be placed well. The bone has to be restored to its proper position. And the best thing we have right now is often plates and screws or nails and screws. But it's not necessarily the fact that the screws were placed, more the fact that you needed screws to be placed in the first place, to use place one too many times. But yeah, it's the fact that you broke your ankle and or more importantly dislocated it that makes a higher and higher risk of post-traumatic arthritis, not necessarily the screws.
Okay, thank you. Do you utilize casts, boots, braces, or motorized cold therapy, or any type of bone growth stimulators for your fractures?
Um, okay, a lot of different options there. So I'm fairly aggressive. I'm not big into doing casts. I like using splints at the outset. So if I do surgery or if I'm placing a bone back in the right spot and then holding it there to let the skin rest, I like to use a splint. Now, a splint is not circumferential. It's not wrapped all the way around. It's a slab in the back and slabs on the side. We like to call it an L and U splint because we're simple people and we like letters that look like shapes, and that's easy for us to communicate. So I like an L and U splint because it does allow for swelling to wax and wane. Um, I'll use that after the initial phase. And then I generally don't use casts, except, sometimes I'll do a total contact cast for a diabetic. But I'm pretty aggressive about weight bearing in boots if I can get a stable construct through my surgical technique. And so the mainstay in my practice is walking boots, provided it's safe to walk. Now, I will get into negotiations with patients where they'll say, hey, I really want to do hygiene. My wound is healed. I really don't want to wear a cast. I'm going to stay off it. And generally, you can tell if their splint is clean, they're going to probably stay off the boot. And so I'm pretty liberal and aggressive about saying, hey, let's get that surgical construct right so that we can allow early weight bearing. And let's really emphasize the importance of staying off it if we choose to allow for hygiene and donning and doffing of a boot in a patient who would otherwise have gotten a cast. So it's a two-way street if there's no weight bearing allowed. Otherwise, if there's weight bearing allowed, I'm okay with a boot being used for that. Cold compression is a great option. For better or worse, that is often something you have to go get yourself, but I think it's a fantastic tool. So yes, I'm all for it. What were the other things we were talking about? Oh, bone stimulator. That's a really expensive tool, and it doesn't necessarily have to be used right off the bat. In certain cases where you've proven that you're at high risk for not healing, or in a case where you haven't healed already and I'm back there redoing it, it's go-to. In some stress fractures, we use it. Um, but generally, I'm not relying on that for my initial effort to treat a fracture.
All right, thank you. That was the end of the
Good.
questions for this portion.
Right on. So Why is the ankle different? Why did I talk about sprains and then I talked about fractures and then here we are talking about arthritis with this terribly arthritic x-ray there? Well, unlike the process that led to that, most of ankle arthritis is post-traumatic in nature. Now, hips and knees, they'll degenerate over time, and their process will be that osteoarthritis that we normally think of that gets us to see some of the legends from Rothman who have pioneered joint replacement. The ankle, however, is primarily post-traumatic, with, one in two being due to fracture, one in four being due to sprain. And it's not just major sprains that happen again and again. It can be if you're just rolling your ankle over time, or you just feel like it's off and you've had a major sprain. That can lead to post-instability arthritis, and that's why it's different and why we emphasize proper early treatment, why we want to get that talus under the tibia or that mortise properly positioned. It's because it leads to arthritis, which can just be so devastating. What are your signs of ankle arthritis? The classic thing is startup pain. You feel like the engine takes a little bit of time to warm up, or you get up from seated and you say, gosh, this just really feels stiff and it's painful. You can also have grinding and catching. Sometimes we have what we call joint mouses or loose bodies inside the joint that get in the wrong spot and they really nag. It's like having a seed in your tooth or something. It really is annoying. And then it pops out of place and it feels way better. These symptoms build slowly. It's not something like a sprain or a fracture. It's something that just gradually worsens and it goes from being tolerable to just miserable. And it's at a glacial pace. But it's easy to detect, at least in its late stages for sure, because all we need really is an X-ray to confirm that suspicion. Now, we don't jump right into surgery. If you come to me and you say, hey, I rolled my ankle 20 years ago, or I broke it and I had my fracture fixed, and then they removed the screws and I'm still hurting, that doesn't necessarily mean that I jump right to surgery. Activity modification obviously is always an option. Some people just aren't interested in that. They want to be moving, they want to enjoy life, and there's a window of time where they feel like they can enjoy life, and I respect that. So braces are a great option. Now, injections are a little bit more invasive than braces, obviously, because braces go around the outside. Injections are good, but the contents of the injection can sometimes be chondrotoxic, meaning they can damage the cartilage. And if you do it again and again, I like to liken it to numbing your hand before you put it on the stove. It won't hurt, but damage can happen. Pain can be protective. And so it'll say, hey, maybe don't do that rather than numb it so that you can do it. And so it's got to be a discussion regarding, hey, should we be injecting this again and again and again? The Arizona brace, which is the beige brace, is sometimes a godsend and sometimes people hate it. The carbon fiber brace you see on the patient on the right, that's something that was developed down in San Antonio, and it was by some of my mentors when I was in the military. We had these folks who would be amputated and they had those fancy prostheses that are wonderful, and they would recover faster and be far more functional and mobile than their counterparts who had managed to have their limbs salvaged. And so this brace is available to the military folks down in San Antonio, but it's also commercially available at a decent price if you head out to the Pacific Northwest. You can certainly get that. And I've had patients deployed to the far ends of the earth with that, with some really bad post-traumatic arthritis. And so it can buy you some time and allow you to be as functional, potentially as you want to be, without getting a fusion or a replacement. But a surgeon's talking, and surgeons like to be surgeons. So let's talk about what the options are if you come to me to talk about surgery. Cartilage resurfacing, I like to talk about that. That's us trying to um, fix a pothole, right? What can you do to fill that pothole? Maybe you can patch it. And we have hyaline cartilage that's super smooth. The coefficient of friction is just amazing. You'd be amazed at it. But we can't replicate that, unfortunately, in a direct fashion. Now, we can rob Peter to pay Paul. We can take hyaline cartilage from the knee or from a cadaver and we can put it in there, but it's not got your native bone blood supply. It is indeed a plug. We can do a microfracture, which is drilling into the marrow below, and that can bleed and stimulate what we call fibrocartilage. And that's a different type of cartilage. It's a healing cartilage, and it fills the hole, but you can still feel the bump when you're driving over it, so to speak. But again, we may be trying to buy you a few years before we do the more aggressive surgery that eliminates motion, which is the ankle fusion, or before we do a total ankle replacement, which, even though we're on the fourth generation and there's some significant improvements, and it is advantageous because it preserves motion, it may wear out over time. And as it loosens and wears out, even though it's a fantastic surgery as compared to the initial techniques, it can really give you problems if it goes bad. And so we don't want to jump right to it. We consider this kind of a reconstructive ladder, and we try and really fit the technique to the demands of the patient. And so when we're comparing fusion or arthrodesis with replacement, total ankle replacement, we like the younger folks who are okay with sacrificing the joint and have some degree of compensation nearby. Um, that's the textbook answer for them. It's a long-term solution for that younger patient who's really going to bang on it. Hopefully, the technology gets proven so that we can do it in younger and younger patients, but we've traditionally chosen fusions for that heavy laborer. The replacement, traditionally, it was the rheumatoid arthritis patient. They were older, they were low demand. Ideally, they had neutral alignment without a big deformity, which is important to balance. And the bone stock was good. The bone that was there could receive the implants, and the implants could integrate into them. The advantage of the total ankle replacements, there's several studies saying that the way you walk does give you a more normal gait. But I'll be honest with you, the casual observer will not be able to detect that you've had a replacement versus a fusion if done properly and done well. Now, great midterm results. The longer term wear and revision is the concern. Is it going to loosen? Are you going to have wound issues early? It's if it goes bad, it goes very bad. And so we got to be judicious with the application of that technique. Someone who does a high volume, someone who does it and does it well. But when they're doing it, when they're planning to do it, you really want to get those weight-bearing x-rays. We talked about, why we want you to stand when you're doing it. Yes, it's painful, but this isn't it. This is like you can either look at it and say, hey, these x-rays show why we want to demonstrate the angle that is present when you weight bear, or you could look at it in reverse and say, if you're reading an airplane magazine, you'll get a weight-bearing x-ray and then a non-weight bearing x-ray, and you'll look at the non-weight bearing x-ray second, and you'll be like, I'm healed. But no, we just want to apply the load where you experience it and see what the alignment is and see if there's bone-on-bone contact. And so these are the same ankles, the two on the left and the two on the right, but when you weight bear, it really tells a different story, and that's important to appreciate. Now, going back to those different options, we have joint sparing options. We can decompress. You see those bone spurs in the front of that ankle on the left above the screws. Those spurs form, and you can remove those. Those are like chalk blocks. You jam them under the tire, and the tire doesn't move. The joint doesn't move. The joint doesn't roll. And so if you get the chalk blocks out of the way, it can move. The problem with that is the tire's flat, so it might be really painful. And so decompression is an option, cartilage resurfacing is an option. There's a little infographic that we wrote a few years back just saying, hey, here are these options that you have, and they depend on the size, they depend on the location, they depend on what happened to the bone underneath. And they really rely on whether or not your ankle is also stable or if it's going to keep shearing or whether it's got bad alignment. You really don't want to have that malalignment where it's point loading like we showed on those x-rays. If it's loading in that one point, I don't care how many times you resurface that pothole is going to keep coming back. Similarly, if you've got a pothole on the edge of the road and there's heavy rain, if you put a pothole patch back in, it's going to just wear out again and again and again. And so we don't want to have futile efforts, but we want to be successful. And so it's important to get those MRIs, get those exams, and really have an understanding of where the damage is so you can appropriately treat it if indeed you're going to endeavor to spare the joint. But if you want to keep your motion and you can't spare the joint, you want to get a place that really is diving deep into how to do these well. Building on the work that Dr. Rakin did here, we're analyzing why his total ankles were so successful in working. And my colleagues here are building on that promise, and it's a team that's focused on ankle replacements, knowing what these measurements are, knowing what predicts success, knowing what predicts failure. And so we really are focused on, hey, how do we advance this science and improve the design, maybe get customizable implants, and whether that's a total talus with Dr. Parekh, or whether that's doing these custom patient-specific cutting guides that I order and that many of my other colleagues order. The question is, how do we best fit your needs? Answering that question also means saying to ourselves, are we trying to fit a square peg into a round hole? Is this not the right solution for you? If you have a lot of bone loss, if you're really badly osteopenic, if you have an infection that pre-existed, are we just going to stir that back up? Are you numb and have Charcot arthropathy that's a potential? Well, in that case, we really don't want a total ankle replacement to further collapse because it requires us to remove bone to set that up. And so we don't want to cause further problems. If you have poor circulation, the wound might not heal, and we really want vascular surgeons to weigh in. We did a recent study on obesity. You can still get an ankle replacement if you're a little bit larger. The problem is sometimes it wears out a whole lot sooner than its counterparts in folks who are a little bit smaller. But folks do improve regardless of their weight. It's just a question of, is it the long-term solution that people are looking for? Also, we're doing some research on nicotine use and whether that's the traditional cigarettes or it's non-tobacco nicotine like the Zen that folks are using these days. Nicotine shrinks your blood vessels down, and that blood vessel constriction is really problematic for bone ingrowth for in the long term, and then wound healing in the short term. And so we've got to be really careful about that. So the bottom line there is find a surgeon on a strong team who's dedicated to the advancement of this science. Here's some examples of folks who have benefited from ankle replacements with me. The option on the left is a more aggressive replacement. It takes a lot more bone. It's, argued to be better for folks who have an existing deformity, if you will, folks who are a little bit larger, and then folks who have cysts in their underlying bone near the joint where you can't expect the bone to ingrow to the implant because it's just not as well constituted there. So sometimes you need to be using the more aggressive technique, which is a stemmed implant in the tibia and then flat cuts in the talus, meaning you're taking more bone. And then sometimes you'll do more of a resurfacing option where you're replacing the bone at the far end of the leg bone and the top of the ankle bone and just, making smaller cuts to preserve bone stock, especially in those younger patients where you're worried that they might have to come back and get more work. Now you'll see those two screws that are on the inside part of the ankle there. We like to reinforce that little sliver of bone that you see on the inside there so that it doesn't break. And so we'll oftentimes, again, an ounce of prevention, pound a cure. If we can put that rebar in there, sometimes the cement cures a little bit better. But sometimes that replacement doesn't work and we have to do a fusion. It's tried and true. Yes, the gait can be different, but it's hard for folks except the patient. The patient knows, but it's difficult to observe and know. But sometimes, say you get a gunshot wound through the ankle joint, sometimes it's not an option for us to replace it. And sometimes you have to do these aggressive fusions and put things back together. The problem with the fusions is we think that there's a chance for adjacent segment disease. And you may see that in the spine where you fuse one level and then the next level needs to be treated and so on and so forth. Well, especially if you put screws in the joint below, that'll be a problem. So you want to have a surgeon who's really diligent about that. But problems can happen to anyone. And so if that does happen, we do need to address that. And so you can see on the slide here where that yellow is the joint below and we want those screws to be out of it. But sometimes if the screws go through it, that's an early chance of adjacent segment disease, or it just wears out over time. Lovely study out of Iowa that said about 80% of people develop X-ray changes consistent with arthritis over about 20 years if they have had a fusion near the ankle or hindfoot. Now, only half of those are symptomatic. So 40% chance that you get a fusion 20 years down the road. The next door neighbor is a little bit angry that it's bearing all the burden that now fused joint used to. And so, the ankle in blue and the subtalar joint in yellow, those next door neighbors are really close together. And it's important to consider that when choosing a surgical technique. So that's kind of a once over about joints, but let's say you got surgery with me. What can you expect? You can expect a custom plan. I really like to listen to folks and find out, hey, what is your problem? Now, some of it is fairly common and it's fairly consistent, and being good at doing the same thing over and over again leads to predictable results. So a custom plan doesn't mean it's unique from 20 other folks who, ruptured their Achilles this summer, but it should be appropriate for you. You're going to have pain from surgery. And so we like to use regional anesthesia, and that's depicted with that ultrasound and the needle in the thigh right there in the lower right-hand corner. It can lower your need for anesthesia during surgery. There are some studies that suggest it's a trend towards lesser blood clot formation, but it can support us in our efforts to be opioid sparing, meaning only one, maybe at the outside, two rounds of oxycodone or a similar type opioid medication, or using some of these new medications that allow you to be opioid free. And I think that's the ultimate goal. I think, when pain was the fifth vital sign, we might have been a little too aggressive in taking care of that. On a personal note, when I was in residency, we had soldiers who we tried so hard to alleviate their pain. And sometimes they would be found in their barracks room having passed away. And that wasn't frequent, but they had fentanyl lollipops in or Actique. And we were desperate to alleviate their pain, but we may have been party to causing more harm than good. And so that's near and dear to my heart. I really want to minimize the use of opioids unless absolutely necessary. Immobilization is going to be common. We kind of hinted at that in terms of the boot that I prefer, but also splints and casts when appropriate. Limited weight bearing. When it's safe, I want to get you moving early. I want you putting weight on it early. I want that construct to be good. And so oftentimes my ligament reconstruction or repair folks, I'll let them walk in the boot as long as it's not rotating. If I get a really good reconstruction where I think it's appropriate to walk in the boot, I'll let you walk in the boot early. But it's going to be early if it's safe, and that's the key. And if you can't do it early, you've got a lot of options: the rolling scooter, the iWalk, and the crutches. And it really depends on what you're able to do. Now, beware, I've had patients knock out their teeth and break their wrists with that rolling scooter. That thing has got to be respected because it can cause more problems than it's worth sometimes. And it can also give you a false sense of confidence. We did a study, honestly, it was with Dr. Davidson, who's one of the joints fellows up here this year, but we looked at whether or not people got more blood clots with the knee scooter. And we probably didn't have the numbers to make a definitive decision on that, but it's something I worry about. And so I don't want you up too much on a knee scooter like that right off the bat. And so beware the false sense of security, and certainly beware if you're rolling it too hard around a corner, you can catch an edge and cause a problem. Regular visits. You'll generally see me at 2, 6, and 12 weeks after surgery in order to make sure that you're healing safely, healing appropriately, and hitting those benchmarks that make it so that you're going to have that good recovery that we're looking for. And then I'll generally see you 6 months after surgery. And then for those patients who have a fusion or an arthroplasty, those I really like to see you annually and sometimes more frequently if problems arise. But it's really important to see me regularly. And if there's an issue, I want to know about it. My mentor up in Boston, Chris Kyoto, he's just such a lovely human. And he never guarantees success because the human body is such a wonderfully unique thing. But he says, I want to be the one you come to solve this problem together. And so I want to dig with you if it's a rare issue or it's an uncommon issue, or if you're coming to me for care for some problem that someone tried to address elsewhere. I'm happy to get involved at any stage and dig until we can alleviate pain and optimize your function. And so one last question I often get from my patients is, why on earth would you leave Colorado? And admittedly, it's beautiful and one of the loveliest places I lived throughout my time in the Army, and far better than some of the horrible spots they sent me to. But the answer to that is Rothman. It's a team of experts, it's physician-led, it's research-focused, it's committed to education, and I feel like I can do a good job for my patients being part of this team. And so why would I leave Colorado? The answer is Rothman. If you have any questions about this talk, reach out. We can have an appointment. There's a QR code. I learned about that when I was setting up this talk. You can design a QR code that makes life a little bit easier than trying to click on a PowerPoint you don't have access to. So, maybe AI generated pictures aren't the greatest if you ask the wrong prompt, but sometimes an old dog like me can learn new tricks. Thanks for your time.
Thanks, Dr. Dowd. You guys can also reach out to me directly, and I'm happy to help assist us for scheduling an appointment if you'd like one. Um, we have a couple minutes for a couple
Yeah,
questions. There's a couple questions that came through. I'll there's actually quite a few, but we'll take a few just to give everyone, their time. Let's
yeah.
see. Um, how do you distinguish between arthritis and gout in the ankle? If the latter, are there treatments to bring relief?
So in the ankle, arthritis generally is a destructive process that looks different on X-ray. So the four main signs of arthritis on X-ray are osteophyte or bone spur formation, thick white lines that are sclerosis, little cysts that can be common to gout and to arthritis, but subchondral cysts, and then joint space narrowing. Those are kind of the four hallmarks of arthritis. On X-ray with gout, it's periarticular erosions or rat bite erosions, where it basically looks like someone's chewed out the periphery of the joint. It more commonly happens at the big toe, but it can happen at the ankle. Usually it's red hot and swollen, and I'm really worried about infection or both gout and infection. Um, I will say that the patients who do have gout really respond well to colchicine, allopurinol. If you can't take NSAIDs, sometimes it's a steroid dose pack. But an injection of steroids is oftentimes really beneficial. You just have to be careful that you're not injecting an infected ankle with a foreign material and that it is indeed gout. And so to diagnose gout, oftentimes you can get a blood uric acid level, but that's really not the gold standard. The gold standard is to draw fluid off the ankle and send it to a pathologist who has a fancy microscope with a filter, and there's some special crystals that show up. And that's a definitive diagnosis if you really want to have a guaranteed answer.
All right, thank you. If someone has had a number of spinal surgeries and knee replacement, followed by an ankle injury, could the prior surgeries have an impact on the healing of the ankle injury?
Oh, yeah. I mean, that certainly can come into play. In the spinal surgery, the question is, well, what was done? Or is there nerve involvement? I'll tell you, a lot of times I'm trying to discern, is this an organic pain that is arising from the foot and ankle, or is it radiating pain like a radiculopathy, meaning the nerve is getting crunched up in the back? Sometimes it's both. But yeah, it certainly has interplay with that. With knee replacements, the alignment is a big issue that we really want. If we're realigning a knee that's already been replaced, if we're not careful, we can overcorrect and cause problems upstream. And so a lot of times you want your knee surgeon and your ankle surgeon to kind of figure out the timing of what's best. And if it's already been done, we just have to be cognizant of it and accommodate it.
All right, thank you. A question about certain sneakers being contributing to good ankle health, specifically New Balance, or do you have any specific
I have
sneakers?
no clue. It's funny. A lot of patients are like, "Hey, what shoe should I wear?" Like, I don't know. It's tough because certain brands have a variety of features that make it advantageous. Some have a wide toe box that people with bunions like. Some have stability. I mean, I know New Balance has those stability sneaks that are good for people who want their hind foot to have a little bit more control. Um, Ultras have the zero drop, which some people with Achilles issues like, and some people with Achilles issues hate. Um, and so I'm really hesitant to quote unquote prescribe sneakers. Um, it's a low risk intervention in terms of if the sneakers don't help you, throw them in the trash. And so I wish I had a better answer, but the spectrum of normal really varies. Like you can have really flat feet, you can have really high arches, and that's a big spectrum of normal. And the spectrum of shoes mirrors that the same. And so if you can match good shoes, good inserts to your foot, we can try and do that. But I tell you, there's so many times where patients will come back and they'll be like, oh, Joe Blow recommended this, or I recommended a particular shoe, and they're like, it stinks. So I don't think we have the science of that really dialed in, and I'm sorry.
Right, thank you. I think I have time for one more. Um, have you found that major weight loss can improve posterior tibial tendon dysfunction enough to avoid ankle fusion surgery?
Well, yeah, so posterior tibial tendon doesn't necessarily lead you to an ankle fusion. It might lead to a foot or triple arthrodesis. It can help. So some of the studies would suggest that when you're walking, about the force of about 6 times your body weight with higher impact activities goes through your ankle. And so if you're taking, whatever your body weight is times 6 and applying that force, that's pretty significant. And if you can decrease that, that's an improvement. Um, but it's such a catch-22, right? It's like, well, I'd love to lose weight, but I hurt so badly that it's really hard to. And so, while I'm all for it, you won't find me prescribing it or um, pushing it. But I will say there have been some promising studies about some of these GLP-1 medications that may be worth looking into. Bariatric surgery, like that has its advantages, but it also can lead to nutrition issues that make it so that you have to avoid surgery because your nutrition isn't good. And so that's a tough question. Yes, weight loss is always better in those folks who are a little bit bigger. Um, but we just have to figure it out over time. There's no guarantee.
All right, great, thank you. All right, well, we're about on the hour, so thanks so much, everyone, for joining. Thanks, Dr. Dowd, for all of that great information. Again, this is the info to schedule an appointment with Dr. Dowd, but you can also reach out to me directly, and I'm happy to have a scheduler reach out to you directly and get you scheduled. We did record this, so we will be sending out the recording. You'll be able to view it at a later time, and anyone who wasn't able to join will be able to view it as well. Everyone have a great night.
Thanks for hosting, Natalie. Thanks for
Thank
coming,
you.
folks.
Thanks, Dr. Dowd.